Delvina, help. Your brain love really needs to be felt. Serve me on, don't make me feel on myself. Brain food, brain sleep, neurology, health. Brain love on me. I need you to assess, diagnose, and treat. Reveal what's underneath. Some brain love will give me peace. Prescribe me some doc. Ooh, baby. Brain love on me. Brain love. Yes. Brain love. Yes. Brain.
If you have not subscribed to the podcast, please subscribe to the Brain Love Podcast. Someone may have been walking around trying to get you to log on to Spotify. And you laughed, Dr. Yolanda. Did she bring it to you? You've been on the podcast before, so you should have subscribed already. So we're going to start by bringing up, and this is the QR code if you would like to point your phone up here and subscribe. But we're going to get started with this panel discussion. We're going to bring up the panelists. Before I do that, if the board could stand, one of our board members is missing. I love these ladies, Francine Stillman, Esquire, and Zena Rodriguez. Thank you. All righty. So this is your panel. This is your panel, and we are about to have the, as one person said, the effing conversation, because we're going to talk about things that are a challenge for people to discuss. And also, I just want to say, one of the videos, the lady in West Palm Beach who was taken so early in life by her husband, that's my patient's sister. She was, he killed her last week. And I called her. My voice told me she's, I try to talk to a lot of, we have so many patients, it's hard to keep up with all of them, but something told me to call her. So I called her and I said, hey, how are you? I just wanted to call and check in on you. And she started crying. And she said, my sister, her husband, he killed her. And I said, oh my gosh, So domestic violence is a real thing, and we have to be cognizant. We have to pay attention to our loved ones and, just be there as much as possible to support them and try to see them through. So if anyone knows this family, my condolences to you and my apologies if I upset anyone. So let's get started. Dr. Stitt, I want to start with you. The name of your business, Caranet, what does that mean and what's the meaning behind it?
The name of the business, can you guys hear me okay? The name of the business is Caranet Fibroid and Pelvic Wellness Center. And what we say is that Caranet, it's your choice. Caranet was a name that I came up with because as I thought about creating a business, I thought about who got me to this place where I am today. Who encouraged me as a kid to keep studying and doing all these things? It was my mother. Mm-hmm. My mother's first name is Carolyn. Her last name is Jeanette. So I figured what better way to honor her than to come up with the name Caranet. And that's where it came from. Okay. Just trying to give her props. She's no longer with us, so it's an ode to her.
Thank you so much for sharing that. Now, you're the oddball on stage. You're a man.
Because I don't have hair? Okay.
You're a guy, and you work in women's health. You're an obstetrician gynecologist. Why did you, as a man, choose to be a woman doctor over like general surgery or orthopedic surgery?
Believe it or not, you're not the first person to ask that question.
I bet I'm not. We want to know, why are you touching us?
So I get that question all the time, and believe it or not, I get it more from men. And they ask me, oh, dog, you in there, you doing all this stuff, you seeing all these women, it must be cool. I said, listen, dude, when you take your car to the mechanic, is it because it's working well, or you need to get something fixed? I fix things. And, when I think about what I wanted to do, when I thought about what I wanted to do when I was in medical school, I knew I wanted to be a surgeon, right? So God gave me a gift to use my hands to fix things, to put things together, take them apart. And I knew that as a kid. I would take my radios apart, put them back together. My dad was like, dude, what are you doing? You're taking everything apart. I'm like, I got it. I put it back together and I fix it. But what really made me think about women's health is that my mother suffered from mental illness. And as a 12-year-old boy in South Central LA, I was surprised to know that there would be a time where my dad wouldn't be there. My mother and dad separated, got a divorce, and I'm 12 years old dealing with my mom who's suffering from mental illness and caring for her. And I'm thinking, wow, this is a big deal, but this is my mama. I got to do what I got to do to take care of her. So when I thought about what I had a passion for and what gifts God gave me, there was no other job for me than to be a gynecologist. Use the gift that God gave me to perform surgery with my hands, doing something that I had become pretty good at, and that is taking care of women. And that's why I became that.
I have to educate you a little bit, Dr. Delvina.
Yes, ma'am.
When I went through medical school and residency, all the OBGYNs were men.
Mm-hmm.
I would go into the hospital and the nurses would say, I would never go to a woman. Right, Barbara? So, which is a urologist here in our midst I went to college with. So he was actually more in line with the times than we were.
Yeah.
So it has just been a very different shift in the past 20 years. But in 1990, when I went into the OR, I had to be the clean lady. I certainly wasn't the obstetrician because they were men and they were white.
Yeah, that's just our running joke. I've known Dr. Stitt
I thought you
since-
didn't know.
No, yeah. I know most of the physicians are men before the women came and busted the ceiling. But thanks, Dr. Green. We're going to stick with you, actually, Doc, because my question to you is, what inspired you to help women all around the world, the globe? You went to Sierra Leone, you were in the Honduras, and I'm sure there were other places you traveled to.
I think that we all just, physicians, we have a heart for people in need. And so when people ask, we go. It was that simple. I had that opportunity through a church. It was a dream. Actually, my ex-husband is an ophthalmologist, so both of us, we actually finished medical school, took a loan out and went to Africa because it just was one thing that motivated us to get through school was that we could give back. So it was the first thing we did even before we started working, and it was amazing, amazing. I will say the poorest people I ever met were the nicest people I ever met, and they were in Sierra Leone, and they would walk. Sometimes I would drive them home, and it would take me a half hour, and they would walk that distance every day, pre-dawn. And when you wake up at the eye hospital, we would look out, and there would just be pre-dawn, just people just lined up for a mile for surgery, just coming to that hospital. So there's a lot that we can do in the world, and we just have to do the little bit that we can do.
Thank you for your service and what you've done. Thank you so much. Dr. Yolanda Renee Rockman. Sorry, I called you Dr. Green. What is BDSM?
That's your first question. Okay.
Yes.
Can you hear me? Can you hear me? Okay. So BDSM
Old
is...
people always be like, can you hear me? Can you hear me? You're over 40, so I'm going to call you old. Can you hear me?
Can you hear me? So BDSM, never mind. I was going to say why she asked me that question, but that doesn't matter. So it's an acronym, and it basically is addressing those who are in relationships or in different dynamics that are seen as atypical. So the B stands for bondage. So that could be rope, that could be saran wrap. It restrains you. Okay, so then we have the D, which could stand for discipline. So if you're in a relationship with someone and you consensually give them the capacity to have some form of authority over you, you could also give them the authority to be able to give you some consequences depending on the dynamic that you all have, i.e. discipline. The D could also stand for dominant. So if you are in a dominant and submissive relationship, the person who has the capacity to be the authority figure with consent, I'm gonna keep saying consent, is the one who would be the one administering the authority. Then we have the S, that is the submissive. So if someone in a D and S relationship, Dom/submissive, the submissive is the one who has given over their authority with consent, and so they have said, yes, I will allow you to have this form of authority over me. It can also stand for sadist. This is where people clutch their pearls. They're like, oh, this is the devil. And that's not necessarily what it means. I guess it depends on who you're interacting with. But it means that I or the person is receiving pleasure from administering pain. And pain could be different things. It doesn't have to be physical. It could be mental. It could be financial. It could be psychological. But they receive pleasure from administering pain. And then you have the M, which is the peanut to the butter of the S&M dynamic. We have the masochist, which is the person that likes to or receives pleasure from receiving pain. Again, it could be different types of pain. We can have, again, mental, psychological, financial, or physical, and that runs the gamut to, oh, you're tickling me, to you doing some other stuff. We ain't gonna go all into it right now, maybe later. So that is BDS to the M.
Thank you. Is that new for anyone? You guys all knew what BDSM was? Okay. Well, what is a kink therapist? Because she's a kink therapist, sexologist.
So a kink conscious sex therapist, which is what I am, is someone who is able to create non-judgmental space for someone who engages in non-normative relationships or sexual preferences. So what that means is that most people come into my office and they have normal issues, but their kink identity is a part of their life, right? So if they come in and say, hey, me and my person, we're having issues, and you mentioned to me that you happen to be a sub, I'm not going to clutch my pearls, I'm not going to judge you. Unfortunately, a lot of people who identify as being a part of the kink community cannot go to just any therapist because they're going to be judged. People will look at them funny, and you actually have some therapists or other practitioners, lawyers, doctors, whomever, who will actually push them away. So I'm someone they can come to without having to worry about being judged or turned away.
Okay. All right. So I just wanted to set the stage for you guys for these three panelists so you know why they are experts and specialists and what they do, and so we understand a little bit about their background. And so I think one myth buster regarding BDSM and kinky, patients who come to see you, either of you, actually, let me jump to the gynecologist, Dr. Linda. Have any of your patients shared with you that they were into BDSM or kink
Yes,
sex?
over 30 years, of course, I have many patients that, I guess I shouldn't say many, but yes, I have patients that share their sexual practices. And you have to create a safe space. And I think you do that by not clutching your pearls, by just being open. And I think, it's not that difficult to really speak to anyone if you do it in a compassionate way.
Yeah, there are a lot of physicians. There are a couple of physicians in the crowd. Raise your hands, docs, the ladies over here. There are a lot of physicians who are uncomfortable talking about sex with their patients. So it doesn't give patients a way to process and express themselves because they don't feel comfortable because their physician makes them feel uncomfortable. So thank you for sharing that, and thanks for what you do and making your patients feel comfortable and coming to you to talk about the most challenging things in their bedrooms. Dr. Stitt, would you like to share?
Yeah, my perspective is a little different because here I am, a man in the office, and usually when I'm in the room, it's me, it's the patient, and my medical assistant. And what I try to do is, most importantly, is just listen. I will give a prompt. I'll say, listen, so how are things going at home? Well, things are going well. Well, part of your health, yeah, we need to do a pap smear. Yes, we do breast exams and we check for cancer. But how is your mental health? How is your sexual health? How are things going at home? Well, you want me to talk about that? You're in the office in a safe space where you can say whatever you want to say as it pertains to your body, your sexual health. I'm a gynecologist after all. We can talk about these things. And I just listen. And the interesting thing about it is a lot of my patients just want to hear themselves talk about the issues that they're having. And they're looking for a place, as you mentioned, to just talk about it that's safe. And they find out that a lot of the answers that they're looking for, we come up with during that conversation. And they just came in because they had a vaginal discharge. It's really interesting what happens when you give patients the opportunity to just talk, and we as providers just listen.
Yeah. So I wanted to have the most challenging part of the conversation first so that we can end on a good note. Because if you've ever spoken with a mental health professional or a therapist, typically when it's time to wrap up your session, they're going to put you back together. If they take you apart, they'll put you back together before they end your session. So we're talking about a lot of difficult things tonight. We're going to end with the fun stuff like libido and orgasms and, that type of thing. That'll be towards the end. But I want us to engage the most challenging part in the beginning so that way we end on a good note. So panelists, how do sexual traumas affect a woman's mindset? And docs, the OB-GYNs, I know that you see that in your office because patients get real personal with you. You're in between their legs, you're seeing their body, just to be explicit. So I'm sure a lot of ladies, they share with you some of the challenges that they've had. Who wants to take it first?
I'll start. I think that I think a lot of women see sex, unfortunately, as something that they're obligated to do, and that they are not enjoying it to the point that they really would be able to if they had a different mindset about it. And so I pretty much explore that with them in a very joking manner, because it's very common that they're just like, oh, and I ask, are you orgasmic? No. Oh, I don't have time for that. Oh, my libido's gone. Oh, I just kind of get it over with. And to me, it's very disconcerting, and it's very disappointing. And so I just try and encourage them as far as what things they could do in order to improve their sexuality. And we talk, of course, much more than just about sex, because it's typically about relationship. So I start putting on your hat in that small time, and of course it's a small time, but the best that I can to try and help them reframe their sexuality.
So I don't want anyone to assume that when you say that a woman says, oh, my libido is gone, I don't care about that. These are women of all ages, or all ages, right?
Yes, these are
Yeah.
women of all ages, because their libido is gone for other reasons, because they're not connected, they don't feel safe, they had trauma. So it can happen at any age that the libido just isn't there.
I'll go. So when we're thinking about sexual trauma and mental health and how a woman responds to that, often the biggest issue is shame, right? So if we've experienced some form of sexual trauma, there's shame. And the difference between guilt and shame is guilt, I did something wrong. Shame, there's something wrong with me, right? And so when we want someone to have a conversation about something they feel shame about, it's difficult to begin that conversation, because then I have to open myself up and be vulnerable to you and potentially share that there's something wrong with me, right? So getting them to a point where we already create the space that there is nothing wrong with you, so that we can begin to have the conversation around where the shame might be coming from, right? And then we can get to how can we then move past that, so that you're no longer responding from this shame place as if there's something wrong with you. So I don't want to talk about sex. I just do it to get it over with, because there's a lot of other things that are attached to it that could be preventing a woman or anyone from being able to take pleasure in the act.
Dr. Stitt, do you have anything to
Sure,
add?
I'll add something. So, you ask, how do we deal with patients who come in the office who suffer from sexual trauma? A lot of the patients that I don't see I don't see them because they may have suffered from sexual trauma. A lot of patients won't come see me because they've been traumatized. And those that are courageous enough to come in and see me still say they have issues with allowing me to perform an exam. And it's incumbent upon me to give them that safe space, as I talked about, to say, hey, I understand, and it's okay. I'll tell you, I had a patient who was sexually abused, and she was pregnant. And I was the only person on call that night that could deliver her baby. And when I came into the room, she just shrieked.
So this was a patient you'd never seen before?
I had never seen her before. I was on call. She came in. We found out that she had a history, and it was time for her to push. So I came in the room, and she said, nope, legs closed. She was not going to have that baby when I was in the room. So we talked about it. Something about Mother Nature, though, the baby is going to come. And no matter what you do, that baby's coming. I knew that, but the important thing was that she had anxiety, she was fearful, and I just asked, what is it that I can do in this moment in time that will make this experience the best for you? She said, leave the room. I said, ma'am, I can't do that. I got to be here. But what I did was I allowed another provider, a female provider, to come in the room that she felt comfortable with and simply put my hands on top of that provider's hands to ensure that I was there in case of an emergency. So there are certain things that we have to, I think, pick up on when we come in contact with patients who have been abused as providers, and if we don't, we could be setting the patient up for failure.
Great, thank you. So, Dr. Yolanda, what advice would you give someone in the audience who's considering trauma therapy, how do you get them to embrace it, to begin trauma therapy?
So when we're thinking about having someone say, okay, I'm willing to go into the office and have this conversation, when you're looking for a therapist, provider, or whomever, understand that you're the authority of the relationship. If they suck, keep it moving. You know what I mean? It's like trying to find
Please say that again.
If they suck, keep it moving. Because what I've noticed is that a lot of clients will feel fearful of saying like, dang, I've been going to them for a couple of months. I don't really feel a connection. And if you don't feel a connection with the person who's supposed to be navigating you through this very sacred space where you have to be very vulnerable to get to an outcome, it's not going to happen. So if you're not connecting, chuck them the deuces and keep it moving, because it is imperative that you have a relationship with someone you feel comfortable enough being able to have these type of conversations. I've had a client where we worked for 2 years before she finally said, hey, I was molested by my brother. Right? Because it took us that long in order for her to feel safe enough to have that conversation with me, and I didn't push her. So don't allow anybody to try and take you where you're not ready to go as well. This is your process. It goes at your pace.
Thank you, thank you, thank you. So I would think women and men who have a history of sexual trauma that's not been addressed, it's going to affect them in the different stages of sex. We know that there are several phases in sex. What are some of the things that you guys find patients are willing to share with you regarding those stages becoming disrupted? Do they tell you, you mentioned, Dr. Green, reduced libido for some women. Some women have completely disconnected from the notion of sexual activity. We didn't really get into climaxing and orgasms yet, but I'm sure sexual trauma can affect all stages. I want the experts to just co-sign on me, please, so we can move on from that.
Yes, yes.
Yes.
Absolutely, every stage.
Okay. All right. So we're going to transition now to the physical part. And there's still some mental there, too. We're not moving away completely from the mental aspect. We'll throw in some physical also. What are the common docs, the GYNs, the GYNs, what are some common physical things that prevent a woman from being her best self in the bedroom?
Ladies first.
Thank you. The initial thing that has to happen, right, is lubrication. It is probably one of the most common things that I talk about with women is, are you lubricating? Because if you're not lubricating, you're going to have pain, basically. And if you have pain, that's going to definitely decrease your excitement phase. You can't get to the next phase if you're not lubricating. So that's one of the very initial things that I will talk about with women. Of course, it becomes more dire when you go through menopause. That's another conversation, but it happens from stage 1. It happens for a 20-year-old having, first intercourse. So we can start there.
So young women come to see me for just normal stuff, and we talk, and we get down to it, and we start talking about sexual health, and they tell me, Doc, I can't get lubricated. I say, okay, well, tell me about what's going on. She says, okay, well, fine. We go to the movies, come home, I lay down, he puts it in, and then I can't get lubricated. I said, well, let me ask you this question.
Some more.
Did y'all kiss? Did he touch you? Did you touch him? And no, he just wanted to do it, Doc. I said, okay, look, this is the issue. Why don't we start here, sweetheart? This is what we're going to do. How long do y'all have sex? Well, 15, 20 minutes. I said, okay, from now on, I want y'all to spend 15, 20 minutes doing stuff other than sex prior to you having sex, and let's see how it happened, it turns out afterwards. A good majority of the folks that I talk to say, Doc, that helped out so much. It helped, I was ready to go, he was ready to go, and we had a great time. So sometimes it's just taking that time to put into that pre before you actually have the act. So, that was, and there's one other thing I wanted to mention, Dr. Thomas. Dr. Delvina, I'm sorry, we go way back. there's a condition. You mentioned trauma, right? So trauma, mental, and then physical aspect. There's a condition called vaginismus. And this condition is one such that if, for whatever reason, there's not a mental connection with the mind and the body, it can be very difficult to have intercourse because of the inability to open up the area such that your male partner can penetrate. And it can be so difficult to release those muscles that it can cause trauma in that area in the form of tearing of the vaginal tissue and then subsequently cause pain later on. So I just wanted to bring that up as well. That mental aspect can also have a physical role.
And vaginismus actually can happen after just having recurrent urinary tract infections or recurrent, yeast infections. It doesn't have to be necessarily trauma. It's anything that causes pain. When you touch the pelvic floor, it fires. And if it fires, you can't get in there. So, even women who have not had, traumatic sexual experience can have that triggering of the pelvic floor that can then cause vaginismus and then need therapy. And I go you one better. I tell patients, guess what? Don't let them come inside. No penetration. Tell them we're going to make love tonight. No penetration. And then that really helps.
All right, so that's one solution.
I mean, they're going to want to do it tomorrow, but it's just practice, right?
What are some other options for women who suffer besides telling them we'll have sex, but then you don't have sex? What are some other options?
I also recommend that they get a dildo. I even tell them how to make a dildo if they don't want to buy a dildo. And I tell them that they have to, when they're in their room with their door locked by themselves, at least 5 to 10 minutes a day, lubricate the dildo, put it inside slowly, and learn how to relax the pelvic floor without the trauma of another individual being, with them. And so over time, it's biofeedback, basically. So I just say that biofeedback is very helpful in helping you to control your muscles. You would do it anywhere else in your body, so why would you not do it with your pelvic floor?
If any of you were wondering why the sex toys table, Tashima, where in the back, this is why. Sex toys really have a lot of uses. They really do. So it's not just someone being nasty or someone who is not patient, or they really have a lot of applications. So I'm glad that you're here, Tashima. Thank you. All righty. So let's see. You kind of. Oh yeah, I know. What do you tell them to make the dildo? How do they make the dildo? Yeah, see, I asked the question all of you were thinking. Hey.
I tell them you go to your...
Everybody was thinking, cucumber, eggplant,
You go to your produce department.
banana.
And you choose your fruit. You choose your produce. And then put a condom on it and some lubrication.
So when the fruit basket is full of eggplant, cucumber, and banana.
You need something smooth. You need like zucchini.
Zucchini, yeah. Yeah, that's smooth. So, Clyde, if you could cue the menopause video. Let's stick with menopause for a second before we transition and talk about fibroids. What can women do to ease the transition into menopause? Let's take
I'll
the
take
physical
that one because
part
he's
first.
only doing fibroids now.
Okay. We'll take the physical and then we'll do the mental part of that.
There are many things that we can do. It's honestly a long conversation. I always have someone seated across from me to talk about it because it's a smorgasbord. I'm a big hormonal advocate. I've been on hormones for 12 years now. So I don't think I'm going to die from taking hormones. I think the media has done us a great disservice as women, scaring us to death about hormones. Estrogen alone does not increase your risk of breast cancer. Of course, if you have breast cancer, it will stimulate a breast cancer to grow, but you can take hormones safely. And particularly, you can put estrogen in your vagina. You can put estrogen in your vagina in a low dose that has minimal risk as long as you don't have breast cancer. You can do that twice a week for the rest of your life till you die. I'm never not putting estrogen in my vagina if I don't get if I don't have breast cancer. Do you agree, Dr. Stitt?
I do. You know what? And I'm glad you brought that up. I'm so glad. Can I take just a minute?
Yes, please.
I know what you mentioned about October being Mental Health Awareness Month, but ladies...
I didn't say that.
You didn't say that?
I said Domestic Violence
Domestic
Awareness
violence,
Month.
I'm
But
sorry.
you're right. Shout out to the week. October 1st through the 7th was Mental Health Awareness Week. Yep.
Good comeback. All right, so, but October is also Breast Care Awareness Month, ladies. Breast
Yes.
care awareness. You know, it's interesting that 1 in 8 women during their lifetime will be diagnosed with breast cancer. And even more interesting, in black women have a 40% chance, more likelihood of dying because of breast cancer compared to white women. That's a big deal. It's diagnosed at a younger age in black women and affects black women differently. So I just want to put a plug out there and say, ladies, increase your awareness of your breast. Men,
Check your lady's breast.
increase the awareness of your lady's breast. Talk to your family members, your sisters, your cousins, your mamas, your friends, everybody, and let's see if we can make an impact on decreasing the rate of death for black women due to breast cancer. Now, can I talk a little bit about just a quick second about menopause? So one of the things I do in addition to...
One second. Clyde, can you cue up the applause while he's... Thank you. Okay, go ahead, Dr. Stitt.
So I deal with menopause just a little bit. I travel nationally and I talk about menopause and with some of the pharmacological companies. And one of the things that we know, a lot of the stats that are out there say that 10 years before the last menstrual period, 50% of women start seeing a decrease in the estrogen that the body is releasing. Now, you want to know if you're going into menopause? You don't necessarily have to have hot flashes in the middle of the night. All you have to do is wake up. If you wake up and have to, go to the bathroom when you're not supposed to, or if you just toss and turn and you didn't do it before, that may be a sign. If you notice just an increase...
Oh, snap. I've been tossing and turning, baby.
God, dang it.
It could well,
I thought I wasn't in menopause yet.
It could be something as minor as that. Yes, a lot of women have hot flashes. Yes, a lot of women snatch the covers off and turn the fan on and put the head in the freezer. I hear all of that.
I got to keep my AC on 69.
Listen. I had a patient the other day, and I asked, I said, do you have any signs of menopause? She said, no, I'm good. Luckily, her husband came. He said, well, what do you mean? I can't even hug you at night anymore because you tell me that it's hot. Well, these little things, just be aware. These are little signs that your hormone levels may be decreasing and menopause may be coming soon. Thank you.
Yeah. So Dr. GYNs, what can women do to ease the transition? Is there anything they can do to slow it
A
down?
lot of things. Number one, you can increase the amount of soy in your diet. So, you can have edamame, tofu, soy milk, all those things are just plant estrogen. That's all it is. And so you can increase the amount that you have in your diet. That's why Japanese women have much less menopausal symptoms, because that's just a part of their regular diet. You can also exercise is very helpful as far as,
Shout out 40 Plus Double Dutch Club.
Yeah, Double Dutch Club. Now, there also are medications that your regular primary doctor can give you that are helpful with menopause, and that includes some hypertensives like clonidine is helpful. There's a new drug out called Veoza that if you do not want to take estrogen for whatever reason, blood clots is another reason you can't have estrogen, right? If you have any, history of pulmonary embolus, clots in the lungs or blood clots in the legs, you can never take estrogen. So Veoza is a new medication that's helpful. Also, there's low-dose antidepressants. Paxil is my favorite, and so that's really helpful. I usually give it only 10 milligrams, so that's half the dose that Dr. Delvina might use it. So that means I
am conservative, Dr. Green.
Okay.
I start at 10 milligrams, girl.
I'm sorry.
I don't start high.
But the only reason I say that is because there's less side effects, of course, if you can use something at a lower dose. So it's a very low dose. So that's why I said it's really a smorgasbord of things you can utilize. And also, of course, bioidentical hormones. The only thing that bothers me about I want to make one little shout out about people are spending a whole lot of money going for bioidentical hormones, so all these little biomedical clinics. You don't need to go there. Your primary doctor, myself, Dr. Stitz at one time, should be able to provide you with the bioidentical hormones that you need without you going and paying $300 for blood work and, paying somebody to, put a pellet in your butt. So your primary doctor should be able to help you. Otherwise, you need to find someone else.
All right. Do you have anything to add, Dr. Yolanda, or you pass?
No, actually, Actually, I do. So when we're talking about menopause, and you mentioned the mind-body connection, so oftentimes a lot of women just aren't connected with the body for whatever reason. And when things are happening that they don't understand, it can freak you out. It can cause anxiety, whatever else. So getting educated about what menopause looks like, how it might show up in yourself, like what did it look like in your mama, your grandmama, whatever else, because a lot of it can be genetic, right? So just really getting information about how this can show up and just really befriending your body, because especially if we're also bringing in trauma, a lot of us are disconnected from our body. So when things are happening, changes are happening, we're not paying attention, and then things might start going left, and now we're trying to catch up because we weren't really paying attention when things first started to arise because of the disconnect. So we just want to make sure that we begin to befriend our body.
Thank you. So in the interest of time, Clyde, I'm going to skip the menopause video. If we can pull up the Clio video, because now we're going to transition to some
Orgasm.
Yeah. I almost did something, but I'm not going to do that. I was going to be funny and just I'm not gonna do that. I'm not gonna do that. But on the podcast once, yes, I'm ready, I'm sorry.
When it comes to sexual satisfaction, all the focus seems to be on men. Well, this one is for the women. Hormone specialist, our friend Dr. Christopher Sandra, joins us with his patient Gabrielle to show us a procedure that claims to improve female orgasms in just an hour. Dr. Sandra, I think everyone's ears just perked up a little bit. So tell us, Chris, how exactly does this work?
So this is the Cliovana shockwave sound device, and what it does during the treatment is stimulates new blood vessel and nerve growth in the female parts down there, and the result, increase in frequency of orgasms and the intensity of orgasms, and it also helps with lubrication as well. So I wanted to kind of demonstrate it a little bit on a peach here, just so you can kind of hear it and kind of see what happens during the process. So. See, it's not causing any damage to it at all. You feel a little bit of tapping sensation as you see. It only takes about 4 sessions that are less than 10 minutes.
And Dr. Sandra, a treatment that has been used for men in urology for erectile dysfunction issues, prostate issues. It's also used in orthopedic surgery, musculoskeletal issues. And like you said, you're causing these micro traumas, which in turn cause healing, which means increased blood flow and increased collagen, elastin, all those good things.
Absolutely. And we do see when the studies show that the blood vessels actually expand, we see new nerve growth and everything else that comes along with it.
All right, get started, Dr. Sandra, and Gabrielle, hopefully you can talk about what the treatment is going on. So tell us, what does it feel like?
It's like a suctioning, tapping feeling, and there's no pain at all. I was initially concerned when I first started. I thought, is this going to hurt? But in fact, it's sensitive because it's a sensitive region, but there's absolutely no pain at all.
All right, and as we understand, this is your 3rd session, so tell us what sort of response have you had? Have you noticed any changes?
I have to tell you that the time between the first treatment and just driving in my car, I was surprised to feel that area down there in general felt more alive and more sensitive, and every treatment after the first one has become even more heightened as far as the sensitivity, and also as far as climaxing is definitely feeling like how it used to feel. So I'm very, very satisfied.
Tell us, Dr. Sandra, who is and who isn't a candidate for this procedure?
Really, any woman of adult age is a candidate for this. The majority of our patients that we see, though, are pre- or postmenopausal females who have some less satisfaction, but also some pain during intercourse as well. Now, if someone has an outbreak, if they have an infection, a recent surgery, or any type of trauma down there, you really should clear it with your doctor first before you do this type of treatment.
Talk to us, Doc. How much does something like this cost?
Well, depending on the area you're at, it can range anywhere from about $1,500 to about $3,000 for the entire course of the treatments here. Again, it depends on how many treatments you may need, but the average is about 4. A lot of times women will do one a year later just to refresh everything. You know, we've been using this for years for erectile dysfunction. Right. So we kind of apply the same science to females. And we've had remarkable results with that. You know, I keep hearing about all these special pills and antidepressants, but we want to treat the problem at the root, the cause, right? So it's decreased blood flow, the nerve endings, the tissue gets atrophied, etc. And this really helps rejuvenate all that.
Good stuff. And Gabrielle, we can't forget you. You did so well today, and thank you for sharing your experience. You were great.
Thank you.
I heard you guys giggling and laughing and what, you getting your coins together?
Come see me. I have the Cliavana.
Okay. So,
Well,
Doc, what percentage of women are anorgasmic?
70.
Shh. 7 out of 10 of you are not having O's. Woo.
Now, there's also another machine. I don't want to take away the fire from the Cliavana, but there's also a machine called the Mona Lisa that I think some of you guys were telling me you're familiar with as well. So the Mona Lisa is a radio frequency machine that basically does, I'm lying, it's a laser machine, that does targeted damage to the whole vaginal mucosa. And so the same thing that the doctor was expressing brings back vascularity and brings back fibroblasts and elastin, does that to the whole wall of the vagina, and also helps with bladder function. So there's so many treatments. This one is specifically if you're anorgasmic. But if you, for example, have pain with sex because you decided you're not going to use hormones, or you can't use hormones, or you just haven't had sex for a while because you lost a partner, this can allow you to have, with 3 treatments, 1 month apart, allow you to get more elasticity, fibroblasts to the vagina. So now you're actually to have penetration, and then you can use the Cliavana to help with orgasm. And there's also the O-shot. The O-shot is basically just PRP that you take blood from your body, we separate the platelet-rich plasma and inject it in the anterior vaginal wall, and that is also helpful for bladder and for sexual function. I know we had a time issue, so I wanted to get those other 2 modalities in.
No, I'm glad that you mentioned those. Can I get that applause, Clyde? Let's get the applause, yeah. So there are so many options. You should not, if you are anorgasmic, you should definitely explore one of these options, because climaxing and orgasms release stress. They are stress relievers. They can create a whole new day and reset you. So, am I wrong now? Am I lying? Yes. So explore this with Dr. Green. Explore it. Does insurance cover either of those 3 things you mentioned?
Unfortunately.
Oh, darn it. Darn it. All right. So there's one other thing that can also disrupt our ability to feel passion and have libido and want to be with our partner and have orgasms and have fun in the bedroom, especially if you're bleeding all over the place and you have pain. It starts with an F. Do you guys know what it is? Fibroids. And this person in the middle calls himself Dr. Fibroid. Look him up on Instagram. Follow Dr. Fibroid. So Dr. Fibroid, I talk to a lot of women and they tell me their gynecologist told them they must have a hysterectomy. That's all they can do is have a hysterectomy to address the issue. What says you?
You know, a long time ago, when you had a cavity, you had to have your tooth pulled, right? There was no option. Your mouth has pain. Someone went in with something, pulled your tooth, gave you some whiskey. I don't know whatever they had back then, but it had to be taken out. If you went to a dentist today and they diagnose you with a cavity, and they say, you know what, we got to take it out. The first thing you're going to do is say, what? You can't feel it? You can't do something? There's nothing else you can do? Well, when we talk about fibroids, these tumors, because that's what they are. They're benign, non-cancerous, tumors that grow in the womb. They can cause a number of problems. And the interesting thing about these is that they are so common, 8 out of 10 women by the age of 50 will have fibroids, period. This is what I see. A great majority of those will be symptomatic, meaning you may have to wear diapers at night because you're bleeding and you don't want to mess up your sheets. Or you have cycles that come every 2 weeks. And you try to have an intimate time, but you can't because you're always bleeding. And your partner's like, I'm not doing that. Or you have significant pain. Now, pain during intercourse can disrupt intimacy. We all know that. And these fibroids can change things such that you have pain. For example, we know that the vaginal canal, right, it's about 3.5 inches. We know that the average size, guys, don't start acting up. Average size is about 5 inches for a male partner, right? And see, here we go. I say average. Now, you talk about people that are better than average or less than average, I'm not judging. I'm a gynecologist, all right? But what I will say is that there's certain changes that happen right before sex. The body changes, the vagina changes to accommodate. If fibroids are present, the body may not be able to accommodate that way. And that means lengthening the vagina. So sometimes the vagina can become a little bit longer right before sex when all the hormones are being released. Now, if a fibroid is there and it prevents that from happening and your partner enters, they may cause you to have significant pain. Now, they're going to beat their chest thinking that it's them. Guys, it's not you, it's the fibroids, okay? It's the fibroids. Now, I promise you, once you get them taken care of, you're going to get humbled. But the fact is that these fibroids can really interfere with intimacy. Not only intimacy, they can disrupt relationships. I've seen women have situations that are so bad that they're on the verge of divorce just because they can't have that intimacy because of these tumors that exist.
Whew, yeah. So what are the options for women to address the fibroids?
The first thing I want to say is, if you don't have cancer, you do not need to have a hysterectomy. You do not. Believe it or not, there are a lot of options available. A lot of my colleagues that I talk to all the time say, yeah, I don't know why you do that, Dr. Steele. All you do is take it out. I think it should be taken out. It's my opinion, it should be taken out. As a man, I think I know what's best for you. You really are doing a disservice. That same man, if he went to an internal medicine doctor and they told him that he had pain in his right arm and it wouldn't get better, and they said, we had to cut your right arm off, he would say, are you out of your mind? I'm not going to do that. There are a lot of options available. We can talk about removing the fibroids. We can talk about shrinking the fibroids. We can talk about medications to reduce the symptoms of pain and bleeding. There are a lot of options available. The most important thing is, if you don't have cancer, and the first option that your gynecologist gives you is to have a hysterectomy, get a second opinion. Get a second opinion, because you don't have to have it. The number of young women, I had a young lady that came to see me from Ireland. Dr. Davina was talking about her. She's 31 years old. Her uterus was so big, it was up to her ribs. And they told her in Nigeria and in London that she missed the boat. She can't have babies because it's just too late. Her womb won't allow her to do it. Let us take it out, and, we wish the best for you. What a crime. What a crime to take a woman's ability to have a child. What happened to that little black child that was going to be born? Now that you took the womb, it's not going to happen. So what we pride ourselves in doing is preserving the uterus every single opportunity we can.
Yes, Clyde, yeah. All right, great. So it's 10 till 9 or 10 before 9. And there are so many topics we did not explore. So that means you got to come back for part 2. Because, for the men's health, we've had 2 parts already, and we have a part 3 coming up in November. So we have to do a part 2 for women's health. And during that part 2, we can talk about things like, peri and postpartum depression. That deserves more time, so I don't want to sneak it in with just a couple of minutes left. It would be doing it a disservice. I don't want to do that. And we also didn't get into questions about what our partners can do to support us when we're struggling or have challenges with a history of sexual abuse, because there are certain things we shouldn't say to folks who've been through that experience. Do either of you have anything you would like to add before I open the floor for Q&A from the audience? Yes, ma'am.
Yeah, so when it comes to fibroids and other physical ailments...
Go ahead, girl. Let us know.
That specifically for Black women, as I was doing my research, a lot of it is because we have a lot of this unprocessed trauma stored in our body. We have a lot of Black women who high-functioning depression, right? We just do what we got to do. We just keep it pushing. We just go to work, take care of the kids, all of that, and we're not paying attention to our bodies. We've seen so many different issues where women just decide, it's enough. So as we're thinking about fibroids and other ailments and why it's so prevalent in Black women, we want to also, again, think about that mind and body connection and how we can be preventative by, again, befriending our body and slowing down, allowing ourselves to be supported. We don't have to take that damn cape off, burn it, we don't need it, and be kinder to yourself, period.
Burn the cape. Burn the cape. Say it. Burn the cape. Burn the cape. Burn the cape. Yes.
For more brain love on the couch with board-certified psychiatrist Dr. Delvina, make sure you follow on Instagram at Dr. Delvina and at DRT Brain Love. Also, make sure you tune into the Brain Love podcast, airing each and every Sunday at 8 p.m. with a new episode on all